there. So I'm really honored today to have the authors of an article to present. You know, many times we do journal club and someone takes an article and evaluates it or reviews it, I should say. But I am so excited today that I have agreement from two Creighton University professors, Nicole Piemonte and Cassie Eno, on forming physicians, evaluating the opportunities and benefits of structured integration of humanities and ethics into medical education. And the reason I asked you to speak, I was so happy when you said yes, because I'm totally embedded in humanities education and I'm totally embedded in ethics education. And the idea that you brought these two together, I was like, this is genius. Thank you so much. What a gift of an article. And the idea of using it in the idea of formation of physicians, which is what we're trying to do with humanities and ethics. Like, you just got it all. So I said, if I can get the authors to come, why would I want to review this article if I can have the real people do it? So my real people are here and I'm going to give them the floor. And I assume you have your presentation up as you're sharing. And thank you so much for being here and allowing us to record you. And I'm going to let you begin now. And I'm going to let you introduce yourself in any way you want, because it's much better than what I would do.
Thank you so much, Alice. Can y'all see the slides?
Yes, we can.
Yeah. Okay. Wonderful. So I'll introduce myself and then I'll hand it over to my colleague, Dr. Eno. So I'm Nicole Piemonte. My background is actually in medical humanities. So I have a PhD in medical humanities from UT Galveston, if anybody's familiar with UTMB down there. And I have been at Creighton now for 7 years. I'm currently in the role of the Assistant Dean for Student Affairs for our Phoenix Regional Campus. So we've got a full 4-year medical school in Phoenix. That's where I am. And Cassie Eno is in Omaha. And so we have worked really closely together, kind of developing the ethics and humanities curriculum for our students. We've taught it now for, gosh, now going on 4 or 5 years. I've taught it 3 out here in Phoenix. And so we just want to share with you what we've learned. And I'll let Dr. Eno introduce herself.
Yeah, so great to be here. So thank you so much for the invite. So I had the privilege of kind of getting involved in this work. So I'm a social psychologist by training. So not too far from the humanities field, but also have a lot of expertise in assessment and evaluation. So Nicole and I were fortunate to be able to pair with a nice group of colleagues to do this work and to also include the evaluation component, which is something, as several of you know, sometimes is left behind or doesn't get done quite as well in some of this work. And so it was really an honor to get to work with this group. So I'm happy to be here and present on behalf of our colleagues.
Yeah, great. Thank you, Cassie. So Alice, you posed this question. Did you want to hear from the group, kind of some thoughts?
Yeah, I thought, if it's okay, a little bit,
Yeah,
what is the list of the humanities that can support curriculum in this area? Because I want to make sure everybody's clear with humanities as a big word, not a small word, Nicole, since many people think of humanities as I have to read a book. But when we talk about humanities in health professions education, I think of it broader. So can anybody contribute what their favorite humanities would be, perhaps, if you were teaching through it in health professions education, either for any topic? It could be ethics, it could be professionalism, whatever. Anybody want to throw anything out?
I'm going to keep my eye on the chat.
Or you could chat. If you don't want to speak. Oh, so someone said art, literature, and history.
Yep.
History is great, and art is great, and literature is great. So you got them all, Greg. Thank you. Ethics and cultural competency. So thinking about connecting humanities to cultural competency, which is really help. You can do that.
For sure.
Anybody else have any favorite humanities things they're thinking about? Theater and improv, thank you. We just did theater and improv for the very, very, very first time in all my years of running a humanities elective last Thursday night. I was a little trepidous, I must say, but we did it and it worked really well. So I got introduced to that. Comics are great. Katie, thank you for being here. Comics are great. We also, and movies today, movies, book clubs, podcasts are big. You know, we never thought of podcast and TED Talks as humanities or you know, podcasts really can work very well. Some YouTube clips can even work. So we have to expand beyond the traditionals of those literature. Poetry works fabulous. Poetry has definitely been a big contributor. Cartoons, comics, yeah. Okay, out of time, I'm going to let you move on. It was just like to get everybody warmed up. And
I love that. And these ideas are so wonderful. I love the idea of expanding what we mean by the medical or health humanities. And in our own curriculum, we're going to share a little bit of what we do in our curriculum. In our own curriculum, we do use TED Talks. We do use documentary. Like, we have an expansive idea of what the health humanities are. We're not trying to create some canon of the humanities work that we're allowed to use. It is whatever can kind of develop that affective experience of our medical students. And with that, I want to share a quote that has really guided so much of our work in the creation of what we're doing. So Creighton is a Jesuit medical school, and the Jesuits are very akin to the humanists. They believe in reflection, formation, character formation, and really the liberal arts. So it's worked really well for Cassie and I to kind of throw out wacky ideas of the humanities, because the Jesuit tradition, Ignatian formation, really does support this work. So this is a quote from a Jesuit, and I think it can really guide us. So I'd say students or residents in the course of their formation must let the gritty reality of this world into their lives so they can learn to feel it, think about it critically, respond to its suffering, and engage it constructively. I think nowhere is the world kind of more gritty than medicine and in healthcare, and seeing people suffer or die or suffer from poverty and inequity and lack of access to the healthcare system. We, as medical educators, it is on us to prepare our students for the gritty reality. And that's not going to come from a PowerPoint slide on the statistics of inequity or health disparities. It's going to come from stories of suffering and strength. And that has really guided our curriculum. So too often, I think the medical humanities gets relegated to the soft skills. But for us, being compassionate, being able to hear patients to determine what is the matter and what are we going to do with a treatment plan is not a soft skill. That's the hard skill of medicine, of being able to discern, diagnose, and treat. And so this is beyond bedside manner. But oftentimes we're kind of bifurcating medicine, and we're saying, oh, there's the art and the science of medicine, which doesn't make much sense, because are you an applied scientist who has to like throw some art in from time to time? And are you one or the other in this world or that world? And when we do that, we get ourselves in this really strange bind where we start saying things like, well, I would rather have a surgeon who's technically skilled than compassionate. And I am someone who has had surgery, and I do agree. I want a very technically skilled and very competent surgeon. There's no doubt about that. But I also believe we can ask that person to be compassionate and not just bedside manner. But I am more inclined to follow the directions of the post-op care of someone I trust and who's connected with me and listened to me than I am of someone who I don't think cares about me at all. And that's why compassion becomes kind of the hard skill. So listening, trust, safety, connection, the clinical reasoning to be a good doc requires those kinds of skills. And good treatment plans require knowing that gritty reality of the life of the patient in front of you. And if they have no transportation to the pharmacy, then that's going to change your treatment plan. And we have to get our learners attuned to those things. So rather than seeing medicine as an art and a science that never overlap, I think what we're really talking about is the center of this picture, which is the practice or the praxis of medicine, that it's always a practice. It always involves things like gut instincts and intuition, discernment and experience. And we have to prepare our learners for that messy gray world that involves their whole selves, rather than learning when to be a scientist and when to be a nice person at the bedside holding someone's hand, right? So in our minds, when we was guiding our curriculum, we started thinking, what do our students need? What do our residents need? What do our future docs need? An understanding of the lived experience of illness, suffering, and loss. So beyond the biology of the body, beyond pathophysiology, they need to understand what it's like to live with that illness. We also believe they need this critical understanding of the socio-political conditions. And at Creighton, fortunately, the Jesuits do believe in social justice, and we are allowed to kind of talk about the problems of politics and the problems of the politics of health, and to get our students to start thinking in that way. We think they need a contemplative, reflective, intentional curriculum, one that slows down and asks students to think deeply. We have lots of reflection. Our medical students are writing reflections all through ethics and humanities and submitting them, and they're getting read by faculty. So they're writing and they're thinking. So what are some of the questions they should be asking themselves? Well, what's it really like to be sick or injured or chronically or terminally ill? What is it like to die and face the end of life? What does it feel like to receive a scary, life-changing diagnosis? What does it mean to suffer, and to suffer in the whole sense, physically, emotionally, spiritually? What are the social, political, cultural, racial, class conditions that inevitably contribute to health and illness? And we want them to think about, why were you called to healthcare in the first place? Why? Who are you, and who are you becoming? So for us, it was, how do we teach this? We were inspired by our colleagues, Delise Ware and others, who talked about slow medical education. Now, this is back in 2015. We were talking about the slow food movement, slow fashion, if you remember that. And they wrote an article that was on slow medical education. This was in Academic Medicine in March 2015. And so they said,
Nicole, I just have to say, this is my favorite article in the whole world.
Well, we are kindred spirits, Alice, for sure.
We have to meet.
Yeah, this is a great article that really says, what is slow medical education? It's discussion based. It's not passive didactic. Informal written or dialogical reflection, so small group discussions and written reflection, and a personal emphasis on mentoring and feedback, investing in students in a real and meaningful way. So we think, and I am definitely biased, but it's the medical or the health humanities that create this environment of slow medical education. And this idea of, okay, here are all of these different disciplines. The ones you listed before: art, history, health policy, law, religion, literature, the social sciences. They help us think through the questions of healthcare. So a definition that I like to use is that the health humanities gather together like the wisdom and insights of many disciplines to foster a richer understanding of the human experience of illness, not the scientific understanding of illness, and health and disability and ability and identity and gender and embodiment and healthcare, all of that gritty reality our students are going to be walking into. And really, the medical humanities underscore that medicine is really saturated with existential questions. You can't ignore them. I mean, you can try to ignore them, but they still come up, because there's questions about meaning of life and death. Why do children die? Right? Why are there miraculous recoveries where others are fated to die? That medicine's inherently interpersonal, and that illness and suffering are always about more than the biological body, because when the body breaks down, so does your life. And we have to prepare our students to be able to enter into that. We also think the medical humanities should always be critical medical humanities. This is not about creating a social veneer to make our students look like well-read doctors. No, this is about getting them to critically think about biomedicine and what they're participating in. In this way, the humanities cultivate the hard skills. We think it's the hard skills necessary to recognize and respond to the texture of people's lives, the big picture, the context, because the humanities are going to get them to see the gritty reality. What we have to keep an eye on is professional identity formation. Fred Hafferty at Mayo and his colleagues talk about medical education being a socialization process. It's really similar to like military formation, that people are becoming different people through the 4 years of med school and certainly through residency. because we have to ask ourselves, what kind of doctors and people do we want our students and our residents to become? We have to pay attention to what's happening, because professional identity formation says that this is a transformational process where you become a lay person to a physician, and it involves the establishment of core values, moral principles, and self-awareness. Some of us are afraid to say that we are in the game of moral development and character formation, but that's what we're doing as medical educators. And we have to be able to say that out loud and then create a curriculum that acknowledges and contributes to the character and moral formation of our students. What's tricky is we have to always be aware of the hidden curriculum. The hidden curriculum. So what we say in the humanities class, oh, you should care about suffering and the context of your patients' lives. And then they go into third year, or they're an intern, and they start to learn, oh, this is how we really do things. We're in the patient's room for 4 minutes on rounds. Sometimes we make jokes about the people who are suffering. This is how we really do things. And studies show that that hidden curriculum of what we really do around here has a more profound impact on the formation of our students than anything we say in the formal curriculum. So this is why the humanities has to be something that affects people at their core, and they have to be experiential, and it has to be curriculum that is moving. So when we're incorporating the humanities, here's what we know does not work. Didactic lectures, like we mentioned, offering optional experiences or only having electives in the humanities. It gives the appearance that this is not necessary. This is not core to the curriculum. Now, this one I struggle with, but it is not offering meaningful grades. So when they're graded on the hard sciences and not graded in the humanities, we are sending a clear message. Now, what this results in is people like Cassie and I teaching up front saying, everything's gray. There's not necessarily a right or wrong answer. And then we have to write multiple choice questions for their quizzes and exams that have a right or wrong answer. And we get the irony in that. And yet, if it doesn't appear on their quiz and exam, it can be dismissed as unimportant. You have to be able to integrate the humanities into the curriculum, not one-offs. And you can't make it seem like extra work. That is a constant battle, but we can't make it seem like extra work. And this is because we can't just inoculate students against, the hidden curriculum or traditional medical education with like little doses of the humanities. That's not going to work. We have to kind of infiltrate all areas of the curriculum to challenge the normative status quo of what it means to be a medical student. So I'm going to kind of briefly describe some of what we do in our curriculum, and then I'm going to hand it over to Cassie, who's going to talk about how we've evaluated this. So Jesuit educational tradition it's grounded in this idea of Ignatian pedagogy from St. Ignatius. And it's this idea that you have experiences, you have to reflect on them. Those reflections then change your action. You engage in that action and it starts all over and you evaluate yourself. So we've got students in the context of med ed, they have an experience with a patient. They should reflect on that. It changes their action and then they evaluate, was that action the right one for me to take in this world? Our whole curriculum is grounded in this, not just the ethics and humanities curriculum. Now, this is a busy slide. I just want to create kind of a visual representation of what we're doing for our medical students. So the blue, we've got 3 tracks, blue, gold, and green. The blue track is kind of what you would traditionally see in medical school. Foundational science, MSK, neuroscience, cardio, right? This is their first year. But what I want you to see here is while they're in their neuroscience course, they're also having required educational experiences in the social context of care, medical humanities, ethics, leadership, personal and professional development. And they're also having clinical skills. So in neuroscience, and I'm going to give this example in a minute, while they're learning about pathophysiology and physiology of neuroscience, they're also down in the clinical skills lab in sim and with standardized patients learning the neuro exam. So their clinical skills correlate to the hard sciences. And then in their humanities sessions, we're talking about the lived experience of a traumatic brain injury. We're trying to make this horizontally and vertically integrated. So the humanities are related to what they're learning in the hard sciences. And then that also allows us, when we have to write those multiple choice questions, they're a neuroscience related humanities question. So it doesn't seem totally separate from the rest of their quiz or exam. A little closer look at that gold track. These are the topics. Service learning, patient safety. This is all every single week. They've got a 2-hour session in gold. And so every 4th week or so, they might have humanities, every 3rd or 4th week, humanities or ethics. We'll talk about what that looks like. As Alice mentioned, these are combined, ethics and humanities together. They have 14 small group sessions in the first year, 10 in the second. And they're split between ethics and humanities. I do want to share with you what our humanities curriculum looks like for the first year. Intro to Medical Humanities and Reflection. We have a session on implicit bias and anti-racism. We talk about how doctors think, that they need more than science. Narratives in medicine. The nature of suffering and the lived experience of illness. That's the neuroscience one of the traumatic brain injury. The US healthcare system. How does it work and for whom is it working? Turns out not very many people. And we talk about that. And it's a session that's kind of critical of our healthcare system. The social determinants of health, trauma as an example, and death and dying. In the second year, we do reflections on medical education. Who am I becoming? We talk about the hidden curriculum. We have them go back and read their personal statement from before they started medical school and think about how am I changing? The patient-physician relationship. Is the physician a provider? Are they a partner? Are they an advocate? Are they something else? History and medicine. Does historical racism still haunt contemporary practice? Hard conversation, but an important one. Spirituality and meaning making in medicine. And medical humanities, practical applications for the third year, where we talk about what is this going to mean now that you're going to be seeing patients full time. Give you a quick example of what that neuroscience session looks like, and then we'll talk about some evaluation. So as I mentioned, we want students to start thinking about what does it mean to have an illness, an injury? What does it mean to suffer, a change in your identity? So we have them read an excerpt from When Breath Becomes Air that I'm sure a fair amount of you have read this book from a neurosurgery resident who gets diagnosed with lung cancer and dies and talks about the change in his identity. Again, this occurs in the neuroscience block. So in class, we watched this documentary together on living with a traumatic brain injury. So our students and our residents often see, unless they're in PM&R, they often see the acute care of a traumatic brain injury. They get discharged from the hospital. And then the question is, what is life like now? So they follow patients in this documentary of being in a long-term care facility in New Zealand, actually. They've got amazing long-term care facilities and trying to recreate their identity and living with that traumatic brain injury. And then we talk about this article of brain injury being a hidden factor in homelessness. So it's shocking, but between 70 and 80% of people experiencing homelessness have a traumatic brain injury. Now, whether that's they get the traumatic brain injury because they're living on the streets, or they had the traumatic brain injury and it led to socioeconomic constraints that led to them living on the streets. What this means is our students are talking critically about connecting social determinants of health to lived experience. And it becomes, oh, if I see a patient with a TBI come through the emergency department, should I be thinking like, what is the housing situation of this person? Are they on the precipice of becoming homeless and this is going to push them there? Are these questions you should be thinking about as a doctor, or is that someone else's job? And that's the conversation we have there. Really interesting part of our curriculum are these student interest selectives. Now they're selectives, not electives. Each student has to take at least one before third year. They can take up to 3. And the emphasis is on this social, moral, the gritty reality of health and illness. And so we partnered with faculty in Omaha. They partnered with their undergraduate faculty in the arts, humanities, and social sciences. In Phoenix, we partnered with our state university, Arizona State University, and we bring over faculty in the arts, humanities, and social sciences to teach 5-week courses for our students that are like graduate seminar style courses. Our students are doing the work, the pre-work before they get there, and then having graduate level deep discussions and experiences on these topics. Some of our courses are music, grieving, and end of life, the power of art, drawing, observation, empathy, and medicine. They'll go into the anatomy lab and draw their donor bodies. religion and bioethics, the health effects of nature and art exposure, healing traditions of Latino America, like really amazing courses. Here's one that we did, we still do, but this was back in 2021. And this is Drumming Cultures of the World. What can percussion teach us about community building, collaboration, health, and humanism? A percussion professor came over from ASU. This is them on our beautiful back terrace in Phoenix. And our students are playing indigenous music and understanding what that means for those cultures. The whole class came out to watch them play. It was really, really neat. And this is one in Omaha where Cassie Eno is. So Rachel Mindrup is she's an MFA and a professor of medical humanities. In this course, in this session, she's asking the medical students to stare down at their lap and then draw what they see. And they didn't understand. Why am I drawing my lap, my knees, my feet? When they were finished drawing, Rachel, who has a son who has neurofibromatosis and has been chronically ill his whole life, she said, what you just drew is the perspective and the view of a parent waiting in the waiting room when their child is having surgery. Their whole world becomes their lap. And that way of teaching medical students to see differently, that's got the transformative effect, we believe, on our students in a way that a lecture will never do. And so these are the types of things that we've created for our students that we hope have some really transformative outcomes. So speaking of which, Dr. Eno is going to talk to you about this.
Great, thanks, Nicole. And I would just add kind of one anecdotal comment to Nicole's comments is that, you know, when we first started talking about the Gold Track, it was also kind of a cultural transformation for our leadership and other faculty as well. So they said, you know, we'd love to have this dedicated time for the Gold Track. How about Friday afternoons? And Nicole and I said, we can't do that. No. So the students have 2 hours blocked out on Mondays and Tuesdays, but just some of the kind of humorous now, but not in the moment, kind of reflection of this really does have to be intentional time within the curriculum over kind of a longitudinal period. Okay, so what about outcomes? So as Nicole mentioned earlier, Nicole, we might need to advance that a couple times. So it looks like we're
Yep.
So we kind of approach this, and like I spoke about a little bit before, we really did have a multidisciplinary team. So Nicole and I led the team, but we had faculty from the undergraduate arts and sciences college on the Omaha campus. We reached out to a colleague at ASU that had some expertise in qualitative analysis. We included a couple of medical students. We had a graduate student on the project. So it really was a team with a broad perspective, which I think you'll kind of see why this became such a well-rounded evaluation in our perception. We used the Kirkpatrick model of evaluation to kind of structure the questions that we wanted to ask. So of course we asked about students' perceptions. That was an easy piece. Looked at students' attainment of the stated learning objectives, because like good educators, we wanted to make sure they were learning what they were supposed to learn, but then also picked up on some things that they learned outside of what was stated. And then as Nicole mentioned, we talked about professional identity development, kind of through their behavioral intentions. So this data was all collected from preclinical students. So we have intentions to move that measurement into the clinical scenario. We used a mixed method design to really try and understand those questions that Nicole referenced earlier. So how do we understand the social cultural aspects of health and illness? How do we develop that critical perspective? And do students really have an understanding of the lived experience of illness and suffering? So we, again, took a multi-method approach to this. We spent a lot of time kind of brainstorming when and where we could capture some of these data points. So we utilized part of what is already our evaluation of the curriculum. So we had the ethics and humanities small group reflections or essays that they write at the end of the year that Nicole had kind of referenced earlier. We have an end of year survey that just evaluates our curriculum as a whole. So not necessarily targeted to the humanities and ethics portion of the curriculum, so that we could get some feedback that was independent of their experience within those scenarios. We did some survey results that are not part of this publication, but looking at just measures of identity developments, and then finally some semi-structured interviews with our medical students to get a little bit more richer description of what they were experiencing from these sessions. And that's really where we got some interesting feedback. So kind of paired with those questions that we spoke about earlier, kind of paired our questions to our methods. And this is what we found. So students reported through their essays that, again, are completed as part of that curriculum. They demonstrated engagement with and meeting those learning objectives. So that was kind of our minimum bar, right? We hope they're learning what we anticipated they're learning. But then we dove a little bit deeper to see what else was happening with these students. So as part of the end of the year survey, we found that nearly half of them were reporting that their identity had changed since they started medical school. 1/3 of them were indicating that their identity had some relation to our university missions. That could have been social justice, it could have been reflection, it could have been kind of Jesuit principles, but a lot of students kind of adopting some of those ideas that are integrated into our curriculum. And then finally, we, through the student interviews, found that students were experiencing outcomes that were outside of what we originally had stated or anticipated. So it offered the opportunity for students to slow down, engage in that critical reflection, and connect with their classmates. So there's really evidence in those interviews, which again, were not necessarily, just students reporting in their essays at the end of the year. These are the things that I'm supposed to say. These are students just talking about their experience in the curriculum. And they also recognize the importance of the whole person and patient care. So we did thematic analysis across all of these different methods. So what we found is, again, students recognize the importance of patient stories, of authentic listening, connecting to and caring for the whole person, and really developing an understanding of that lived experience. So beyond what they were hearing from faculty and from these experiences, they were also kind of elaborating to say, these things are really important for me to listen to. And our observation was that their understanding of medicine was just becoming a little bit more nuanced. They were starting to ask better questions, even in sessions that weren't the ethics and humanities. They would, just anecdotally report to us, hey, I asked this faculty member about cost of prescription or cost of care, and they didn't really have a good answer for me. So what should I do? So they were starting to kind of expand that discussion and that dialogue outside of what was happening in the gold track. I think that was a good unintended consequence, put our faculty on their toes a little bit. So I think that was one of the lessons learned, is that really faculty needed a little bit of education around what we were doing as well. And then we'll just provide some student quotes here, because really they tell the story a lot better than we ever could. So personal reflection and conversation with other students in the same position has led to a belief that humility, empathy, the ability to listen are the 3 most important characteristics that a physician can have. Science can not always compensate for the realities like pandemics, opioid abuse, and struggling mental health. The practice of medicine sometimes means making seemingly impossible choices without a structured treatment plan or rule book or diagnostic criteria. And then finally, I've learned that we must take time to reflect on our experiences, to make sure we have given full thought to our decisions, to listen to others, and recognize the humanity behind every diagnosis. We dive deep into how medicine is so much more than applied science. We have discussed how serious illness chips away at more than the biological body. So you can kind of see here that we have these pre-clerkship students at least geared up to understand that what you're going to see is not just a person with a presenting complaint. We're actually going to see a person who is experiencing some sort of illness.
Alice, so
Yeah.
this is our bibliometrics. Did you look it up? Oh, you're muted.
Sorry, I didn't want you to have any noise. Our librarian was not able to join. She usually reviews this, but I'll just do it very quickly. In terms of all metrics, your article had 8 tweets and 1 download to Mendeley, which means perhaps people will use it in the future because they're putting into a bibliographic library. And the number of views on Accessisys, which is a new database that up-to-date counts daily, is unique viewers and downloads, and the numbers can fluctuate. So I'm not familiar with this system. It's the first time Wendy's reporting on it, and she unfortunately couldn't be here. And there were 782 accesses to this. So just to give an idea how the article is being looked at, obviously the journal, it was published, in a journal that many people on this call don't look at regularly, which is why I wanted to bring this article to the forefront of Journal Club. Last month, we did artificial intelligence as our introductory session for the year, September. And that is such the opposite brain of humanities in the way we're thinking about artificial intelligence. So I felt this contrast between artificial intelligence and humanities was really important to bring up early in our academic year with Journal Club. So thank you, Wendy, for that. If you could advance this slide now. So we're really here, before we go to the end slide, to have some discussion now on what people think about the work that was done in this article. I know you mentioned the limitation of getting the time in the curriculum. What other limitations, I would ask as a start-off question, that you've had in terms of the work you're doing?
Oh, okay. So we've had great support for developing this curriculum and lots of limitations. So I will talk about 2. One is we made the gold track required. So the students have to show up. And they have to show up to their green track to do clinical skills, but they still, the blue track, those biosciences, those lectures are not mandatory for them. So sometimes we'll have 10 students at their science lecture, and then we make all 120 or 130 go to the gold track. So they have this expectation of being highly entertained because they have to go. And there is some resistance, why is this 2 hours? This should be shorter. And, students having some resistance to it, but I don't want to blame them. They're trying to function in a system that privileges quizzes and exams over everything else. That's the hidden curriculum. And then they're resentful that they're sitting through humanities or ethics or evidence-based medicine when they could be studying the hard sciences for their exam. That's always going to be a problem until we can create some shifts in how we do medical education. So that's one. The other would be, I think that we need more experts in the humanities teaching within the curriculum. You cannot just have someone who has a kind of an interest in the humanities to stand up there. We need to have content expertise. And it has been incredibly difficult to figure out in our own university, how do you compensate for the time of someone from a different department, different school or college to come teach medical students? And this has been a problem nationally. Schools cannot figure out how to compensate their own employees of the same school when you use a different kind of currency. We do FTEs in med ed a lot, and they use course buyouts, and those don't work across lines. And so then we're struggling to get the real experts in front of the students, which actually makes a better experience for the students and less complaints about having to be there. So that's just a couple things we faced.
I think evaluation is also always a challenge in these areas, just to bring up Cassie's work in evaluation. So I appreciate the qualitative approach as well as the quantitative, because sometimes on a numerical rating, and maybe Cassie, you can comment on this, and then if anybody else has any questions or comments, I want them, is the importance of having both, what that did for you, because students' numerical ratings can sometimes just really lower the morale of people.
Right. Yeah. And so we, what was reported in this article was all qualitative, but we had some quantitative well. that we intend to kind of track students across the curriculum. Interestingly, what we found in like the Jefferson scale of empathy and our intellectual humility scale, when we did the first measurements of them, students were already on the high side of that. And that might be both self-report and self-selection into our medical school. I don't think we have any students in our medical school who don't have a previous record of service to the community, sometimes valued higher than their, kind of intellectual contributions. And so we had some ceiling effect things happening there. From a student assessment perspective, as Nicole said, that was a real challenge for us because, students are going to kind of vote with their feet based on what they perceive to be important for their grades, which is a whole nother can of worms that we could open. But so we had, as Nicole said, some challenges because we really wanted it to be based on reflection. But if we only did the reflections, the students would have been resistant to even, spending additional time with the information just because of the way that they work at this point in time. And so we do have multiple choice questions to assess the sessions. They're all written as clinical vignettes. And as Nicole said, sometimes it gets a little bit tricky. Students want to argue about even the two questions that are on quizzes and exams. They want to argue about whether or not there might be an alternative perspective. So I think that.
Right. Anybody else have any comments who's been involved? I certainly have not done a lot of evaluation. So anybody else have any comments or thoughts on this as content area for our curriculum?
I'm going to stop share so we can
Good.
talk to each other.
That's good. Yes, thank you.
Mhm.
Any other thoughts? Anybody have tried humanities and they want to discuss how or anything?
So Greg, I see your question in the chat. We've talked about doing this again in the clinical domains. Been unsuccessful to get funding because it's going to take a little bit of work to do so. But we've talked about in the clinical setting using simulated or standardized patients or faculty of observation of students with their patients. What we are hoping we'll find is a little bit of reduction in that kind of empathy decline that happens in the clinical years.
Yeah, we were excited about thinking of, could we have standardized patients be giving us some evaluation of the student's ability to kind of connect and listen and some of those skills we're trying to develop. We would love to use real patients, but we know the challenges with that. Deborah, oh, go ahead.
Yeah. Patricia, has any work been extended to GME? And then Ethan saying it's hard in GME. So this is a very important topic for GME, and I've had a lot of lack of success where I am with a very large GME community of incorporating this.
Yeah.
I've done much better at the undergrad level at our medical school, but I just can't find the right champions within the GME world. So I didn't know if any of you have any thoughts on the GME world with they're having this direct clinical experience, and this is such a way to capture things. So any thoughts on that? That came from 2 GME people that are on the call.
Yeah, great question. So I've recently had a little bit of success. I had a resident reach out to me who she had a background in medical humanities in her medical school. And she was emergency medicine and said, I want to bring something to the residents. I said, okay, let's create something. So we created an experience which kind of told them what medical humanities was. And then we did one of those brief reflective writings. They wrote for 7 minutes with a prompt that she gave them. Then they got in little small groups. And we just replaced a noontime conference with this and got them to reflect. It was so incredible. They did it and their reflections were incredibly thoughtful. What worked was that the resident led it. That's what worked.
Yeah.
And so I just collaborated with her, helped guide her. They let her take an elective in medical humanities. I gave her readings. We talked about it. I mentored her. We created it together and it worked. And they were like, yeah, we should do this like every other month. So I think it's really possible.
Yeah, I mean, that's really helpful. I think, as I think about taking up the noon conference time. You know, I know that's coveted time slots, and I wonder if leveraging some of the existing curricular components could be converted from your traditional didactic to this, and developing faculty expertise in facilitating that. It's very, you know, we are very used to delivering didactic content, you know, going up, presenting slides, having some questions, and being done. I think the limitation is, from my perspective, GME faculty that would be comfortable with leading a humanities directed, focused conversation in health equity, well-being. All of these curricular components are already part of, or should be part of, the trainee, you know, the trainee education setting. So
Absolutely. And it's about making slight adaptations. And if you can partner with someone in the med school or any of the health profession schools that's doing the health humanities, you can adapt it, I think, to a GME session.
I think you can. I've had success one year in pediatrics years ago, Pratici's in pediatrics. I had a pediatric resident interested in this, and we did some sessions and it worked. And then she left, and, you know, like nobody else feels comfortable. I think interprofessionally, this works beautifully. This has come up in the chat a little bit. Interprofessional issues should certainly be reached through this for sure. And that is something for us to consider. Teaching and learning moments and some of the other narratives that are in the journals where residents have written stories, certainly are great prompts to bring to residency education. I've used those and really have pointed stories that residents or students or faculty, whoever wrote them, have. Greg, you mentioned a course. Could you please verbalize that course a little and where you're from? Because I don't know you, so I'd like to know that. Can you talk, Greg?
I think it's a different participant, so I defer.
Oh, who wrote the thing about the MBA course?
Right. Please tell us.
Oh, I'm sorry. That was somebody else and you were just responding.
Oh,
It was me, actually. It was Sailaja.
And where are you?
I'm based in India.
Oh boy, go ahead.
Actually, this course was introduced during the pandemic because most of the students didn't have the luxury of working from home. They had to go to the hospitals, and they were getting exhausted. They were complaining about wanting to quit the jobs out of frustration and helplessness of seeing their patients die. And it was like, I had to come up with something really consistent and long-term. And by then we already, I introduced them to the relevance of poetry to healthcare, for self-reflection, for mindfulness, self-awareness, so on and so forth. So now this concept of poetry and healthcare was extended to other arts also, like painting, music, dance. And I've designed a course, an elective credit course, so that they have a choice. All of them may or not want to go for it. And we had 54 students opting, and I did feel it was, when I ran through a survey to know the impact, it was overwhelming response actually, that it helped them in their own stress relief and how they were connecting to their own self and how they were connecting to their patients and how to accept and face your vulnerability than, running away from it or something.
Yeah.
Accepting your vulnerability is important in being able to move forward. Like what we talk about, accepting your patient as a whole person, it applies to our own selves in the first place.
That's right.
So it did, it did help all of us connect in a much better way. It's not just about healthcare providers or healthcare managements and the patients, but even as a teacher and a student, I had an opportunity to witness a very different side of them, and I would consider it as a blessing because most of the other faculty did not get to witness this side of them.
That's right. I think that's been our experience too, that it really showcases a side of the students where they are just so thoughtful. And, we have our perspective of what a 22-year-old might be able to do, think, and say, and they're just extraordinary. So Thank you for sharing that. Really, you're doing awesome work. Okay, Katie, I see your hand is raised.
Thank you.
Yeah, I just wanted to ask a question, actually two questions that I'm going to try to squish into one, if that's okay. They're unrelated. I wanted to ask first about regarding your slides about professional identity development and sort of transformation, this idea of what kind of doctors and people do we want our students to become. And I just wanted your take on, you know, I've had some success with sort of pitching or engaging students with medical humanities by talking about kind of not so much transformation, but more about preservation. Like you are coming into medical school with many dimensions to your identity. You may have this idea that you're going to have to strip them all away and check them at the door. And doing work in this domain is one way to nourish and sustain those other dimensions of your identity that we welcome you as a writer, aspiring writer, artist, aspiring artist, you know, whatever that is. So I just wanted your impression on that. And then just a super quick question, which is for the ethics components of your curriculum, I'm wondering how you navigate students' desire. I find like with ethics in particular, students often want to know like just the legal component of what you're talking about. Like you want to be having a robust discussion about medical errors, and they just want to know, like, do I live in a state with an I'm sorry law? Like, how do I not get in trouble here? And it can suck the the air out of what has the potential to be a much richer discussion. Thank you.
Katie, that's such great comment and questions there. So with the professional identity formation, you are absolutely right. So much of it is preservation or fanning the flames of what's there and good and letting it grow. We're not trying to say, you all lack empathy, let's infuse you with it. They have it. So how do we cultivate it, grow it, not let it attenuate? And empathy is just one minor thing of what we're talking about when we talk about a whole person and a whole learner. And we want to preserve and grow what's already there. So thank you so much for that distinguishing feature. I will say one thing, and then Cassie, if you want to contribute, the ethics, wanting to know the right answer or the legal answer. I do think having them come in, they have to write a pre-reflection before they get into class, and they have to think thoughtfully about a prompt that's not just about right and wrong. And I think it can start to attune them to the gray area, as it were. I don't know, Cassie, if you have other thoughts on that.
Yeah, and I think we talk a little bit about it in the article, but that's also the importance of having the faculty facilitator there, and students even recognize that having faculty kind of in those small groups really does help. They're necessarily leading the group, but they're just there to provide clinical context or to kind of spin a different question. And then Nicole's done something really awesome with, now that we have students who have been all the way through the new curriculum, they're coming back as M4s to be kind of also kind of student leaders of those discussion groups. So they're again being able to have the dual opportunity to reflect on some of those things that they learned previously, but also to provide a little bit of guidance. So part of the role of that facilitator is to kind of walk around those legal issues a little bit. And, you know, step one is blessed, but it has created a lot of feedback from students saying, well, what we actually need to know is the legal consequences of X, Y, or Z. So again, they get that opportunity to take some multiple choice questions, but certainly in the discussion, we try to dig beyond that.
Yeah, absolutely.
I love Greg's comment, and we're going to close out in a minute, but I just want to go to Ingrid. I have about 14 physicians, probably even a little more, who teach in my health humanities class, and based on their humanities focus, some are musicians, some are artists, some are poets, some are, you know, more literary. They pick the humanities they want to use to teach in my course that they're affiliated with. So Ingrid, I agree with you. There are many, many people with interest in humanities from their prior lives, professionally or personally, and those are the people to bring into the courses that you want to offer the students, because they're very authentic. Unfortunately, my course is on Zoom, so some of it is sometimes lost, but we've managed, like we did improv last week, and for the first time, based on a faculty member who's very into improv. He's a family physician. And I just felt like it was not going to work on Zoom, and he felt the same way, but we decided to partner and try it. And with my technical support, we were able to do it. We figured out how to do the art as well. So I think this is important. I haven't brought ethics in as much to my health humanities course, so that's an interesting idea to do some of that. And I might call on some of my ethics colleagues if they want to do that. We're short on time. If we could, the last slide, if we could just put that back on your slide deck. Music is a great connector, and lots of physicians are musicians. Yes, I've had success with music. And this is a survey in our next journal club, which is about professionalism lapses. Do they begin early and continue across the curriculum? We also have the author of the article speaking, who's a dear friend of mine from Harvard Medical School, who's retired now, but wrote this article. And he will be doing his article on November 29th. And there is a survey. I can't thank my two speakers enough. Thank you for coming and representing your article. I did touch base with Wendy, and that data she got was from the publisher of the journal of the article where you published how many people have accessed it. So you should feel pretty good about that number. And the article everybody received, and you'll receive it again with the link to the evaluation. So any last comments? Thank you. And thank you for our guest speakers, and everybody who came seems to be giving you accolades in the chat.
Well, thank you so much for inviting us. It's always such a joy to connect with people who feel that this is important. So keep doing the good work that y'all are doing.
Right.
And really happy to
Right.
meet you all.
And it's great that we can do this across the country.
That's right.
Okay, thank you.
Thank you. Thanks so much.
Bye-bye.
Bye.